Our first speaker, Professor Manoria, is around. Raka, can you see him?
Yeah, he is.
So let me invite Dr. Manoria, Professor Manoria. He is a very distinguished person. He does not need any kind of introduction. He is available in most of the meetings and awardees of many awards. And he has published many national and international publications to his credit. So I will not go into the details of Dr. Manoria. So let me invite Professor Manoria for his talk. Sir, over to you.
Permission. Can I share the slides?
Yeah, sir, please go ahead.
So good evening, Dr. Javed, Dr. Bansal, and Dr. Sudhivanshi. So for the next 15 minutes, I'll be talking on this interesting and new topic, running the race to bottom of LDL in high risk ASCVD, be it diabetic or be it non-diabetic. The last couple of years has witnessed spectacular advances in the field of ASCVD and lipid management, both in terms of enhanced understanding and in the availability of a panoply of newer therapeutic options. All of us know cholesterol never sleeps. It works 24/7 into 365 and is the main culprit for atherothrombosis, which is the leading cause of cardiovascular morbidity and mortality. And therefore, newer and newer strategies are being designed to target LDL cholesterol. So this is the new strategy, running the race to the bottom of LDL. Now, all of us know diabetics, cardiovascular disease is 2 times more common. It occurs 10 to 15 years earlier. And the superimposition of a myocardial infarction in a diabetic further shortens the life by another 6 years. 6 years being already cut off by the mere presence of diabetes. LDL cholesterol has a causal relationship with ASCVD, whether it is CAD or cerebrovascular disease or peripheral arterial disease. And when we look at these 3 major risk factors for ASCVD, we are very clear that there is a J-shaped association between glucose and ASCVD. All of us know if there's hypoglycemia, it would increase cardiovascular morbidity and mortality, and so is also for blood pressure. If you drop blood pressure below 120/80, there's an increase in cardiovascular morbidity and mortality. So there's a clear J-shaped association between glucose and in diabetes and blood pressure and ASCVD. But when we look at the LDL, lowering of LDL is always associated with benefit and no harm. And this is very clearly evident from these slides. Whether it is primary prevention, whether it is secondary prevention, lowering of LDL always provide incremental benefit without any harm. So the issue is why we are so much bothered about lipid management in high-risk ASCVD. This is because this has reached great strides. And what are these strides? When we look at the issue as to whether we can stabilize the plaque, the answer is unhesitatingly yes. We know statins passivate the plaque, they decrease cardiovascular events. When we look at the issue, can we reduce the plaque buildup, which means can we arrest the progression of atherosclerosis? Again, the answer is yes, and we have data from the reversal trial. The other issue is, can we shrink the plaque, which means can we produce regression of atherosclerosis? Again, the answer is yes. We have data from the Acbd trial with PCSK9 inhibitor evolocumab. So we are amidst an era where we can passivate the plaque, we can check or arrest the progression of atherosclerosis, we can regress atherosclerosis. The last issue which remains is, can we make the plaque disappear? This is still an unresolved issue, but active research continues, and maybe in times to come we may reach this goal also. So what is this new strategy of running the race to the bottom of LDL in high-risk ASCVD? Our attempt is to achieve the lowest LDL levels, and this is a guideline-based strategy. AHA, ACC are little behind, 70 milligram in the very high risk, ESC 55, lipid association way back in 16, target 50, ESC, ESC, another target of 40 if you have a cardiovascular event within 2 years on high intensity statin, and lipid association is lowest in the race, 30 milligram target for the extreme high risk, which I'll be talking to you. This shows the research of the last 25 years in LDL and atherosclerosis. All of us know high LDL is bad, as shown by the FOREST trial, by the CARE trial, and the HPS very clearly shows average LDL is not good. TNT showed lower LDL is better, and the improve it further shows even further lowering is better, and the PCSK9 trials, Korea and the Odc, very clearly gave the message, LDL, lowest is best, lowest is best. So when we are treating these patients, particularly diabetics with ASCVD, there are 3 issues involved. We first try to assess the risk of the patient. And there is little difference between the various associations. If you look at the ESC risk classification, the very high risk documented ASCVD, diabetes with target organ damage and multiple risk factors, severe CKD, FH with ASCVD, whereas AHA, ACC, history of multiple major ASCVD events, or one major ASCVD event with multiple. But the lipid association has created a new group of extreme risk, category A, category B. Category A is CAD with greater than 1 feature of high risk, and category B is CAD with greater than 1 feature of very high risk, which is shown here. For recurrent ACS, even if your LDL is less than 50, or you have a polyvascular disease, a cerebrovascular disease, or a peripheral vascular disease associated with it. The second issue is, after assessing the risk, we try to look at the target which should be for the patient. Now, if you look at the AHA is still behind, 70 is the target for the very high risk ESC, 50 is the target, 55 is the target for ESC, and if you have a cardiovascular event, despite high intensity statin, it is less than 40. But the lipid association, as you can see, in 2020 published new guidelines, and their target in the extreme risk group category A, which I showed is less than 50, optional goal is less than 30, and category B it is less than 30. And this is the lipid association guideline that if you are a diabetic and no ASCVD, no target organ, or less than 1 ASCVD risk factor, the target is less than 70. If you have a target organ damage, or more than 2 risk factor, 50. But if you have an ASCVD with diabetes, which is a high risk, extreme risk, less than 50, or if you have with target organ, it becomes less than 30. The third issue is, can we reach these low levels of LDL? The answer is yes. Because as you can see in this slide, if you use high moderate intensity statin, the reduction in LDL is by 30%. If you use high intensity statin, 50%. If high intensity statin plus ezetimibe, 65%. PCSK9 alone can decrease by 60%. If you use PCSK9 inhibitors with high intensity statin, 75%. And if you use PCSK9 inhibitors, high intensity statin plus ezetimibe, you can reduce LDL by 85%. So you can see we can easily achieve the lowest LDL goals. And these are the players for lipid management. All of us are aware of it. Statins, ezetimibe, PCSK9 inhibitors, inclisiran, which is now approved by US FDA, bempedoic acid approved but not available, icosapentethyl approved but not available in our country. Now, we have already witnessed this statin era for so many years, and the key feature of statin is that statins are powered to decrease LDL by 1 millimoles irrespective of the baseline LDLs, and they roughly produce a reduction in the cardiovascular events by 21%, and all-cause mortality is reduced by 9%, and vascular mortality by 13%. And they are very, very safe agent because side effects are very, very rare, as you can see. And for ASCVD, if it is documented, it has to be a high-intensity statin, atorvastatin or rosuvastatin 40, These are the subgroup analysis of secondary prevention trials, and all of us are familiar with. Now, statins are multifaceted drugs. They improve endothelial function. They delipidate the plaque, which can be beautifully seen on a vascular MRI. This is before, this is after, or they can be seen on near-infrared spectroscopy. This is data from the yellow trial. You can see delipidation of the plaque, and they also decrease inflammation. There's a hot plaque in the left main. As you give statin, this plaque becomes less hot. They promote calcification of the plaques, and they have a lot of pleiotropic effects which are useful in acute coronary syndrome. Now, it is very important to understand that ACS, all of us know, occurs due to plaque rupture, but only one out of 10 plaque ruptures culminate into an acute coronary event, and it is the thrombogenicity of the blood at the time of plaque rupture which is the major determinant whether a plaque rupture will culminate in acute coronary event. And statins also decrease the thrombogenicity of the blood. But when we are treating these patients, please do not focus on the plaque cell. You have to focus on the vulnerable blood and the vulnerable myocardium also. And they also have a legacy. How long statins should be used? The dicta is very clear. The treatment with statins is lifelong. If not, life will not be long. Ezetimibe was approved after the IMPROVE trial. You can see a 10% reduction in the cardiovascular events, and the major reduction, as you can see, is in the non-fatal MI, the blue ones, and in the non-fatal strokes. Bempedoic acid is not available in India, but it targets ATP citrate lysis, an enzyme upstream of HMG coenzyme reductase, doesn't produce muscle toxicity, and is a good drug as an add-on therapy. And you can see this is data from the bempedoic acid. It can produce a reduction by almost 20% in the LDL. And this is again clear wisdom trial, where again a 15% reduction in the LDL. And if you use ezetimibe and bempedoic acid, which we use in patients with statin intolerance, it can still reduce by about 36%. Now, PCSK9 inhibitors are the molecule of the decade, because they are very potent agent. They produce reduction in LDL by 50 to 60%. And this is the 4-year trial. Patients with stable coronary artery disease, you can see a primary endpoint reduced by 15%, which is death, MI, stroke, hospitalization for unstable angina or coronary revascularization. MI reduced by 27%, stroke by 20%, and revascularization by 22%. And this is again the same depiction of the primary endpoint in the 4-year trial. Now, when we look at the diabetic subset of the 4-year trial, 40% of them, the benefit is more in the diabetic population, as you can see on the right side of the screen, compared to a non-diabetic. This is the primary endpoint of the 4-year. This is the secondary. Again, you can see diabetics benefit more compared to, with diabetics benefit more compared to those without diabetic. And they do not produce any increase in the new onset diabetes. If you have qualifying MI less than 2 years, the benefit is more compared to if the MI is more than 2 years old. If you have 2 prior MIs, benefit is more compared to 1 prior MI. And LDL, you go on lowering, the benefit is always incremental. This is the Odc Outcome Trial, which again showed 15% reduction in the primary endpoint, CHD death, non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization. And if the data is analyzed with LDL more than 100, the benefit is more. And this is the AVOPEX trial, which utilized PCSK9 in the intensive care during the admission of the patients of acute coronary syndrome, and brought about 77% reduction in the cholesterol. Now, inclisiran is a very exciting agent and now has been approved by US FDA. The beauty of inclisiran is, which is a small interfering RNA, that it inhibits synthesis of PCSK9, and a single dose of 300 milligrams decreases LDL by 50%, and this is sustained for the next 6 months. So you can use the 2 injections per year, and that will be patient friendly. And the Orient program, different trials are ongoing, and some of them have already been published. And then we have this icosapentadine, which was tested in the REDUCE-IT trial, 8,000 patients, established CVD or diabetes with risk factor. These patients has hypertriglyceridemia more than 135 to 499. It reduced by about 39 milligrams. And the primary endpoint, you can see a 25% reduction in the primary ischemic endpoint. And the secondary ischemic endpoint also a 26% reduction. And when the trial was released, there was a lot of enthusiasm amongst the triglyceride group. But when the data was analyzed, it means triglyceride less than 150 or more than 150, the benefit is nearly same in the primary endpoint. And when the secondary endpoint was analyzed, the benefit, as you can see, is more in the less than 150 triglyceride arm, clearly indicating that the benefits of icosapent ethyl are not mediated to triglyceride reduction. Although triglyceride was significantly reduced, the benefits are entirely different. And look at the trial. The trial showed fantastic results. Every endpoint is to the left of the midline, which is very gratifying. And if you look at the confidence interval, none of them is crossing 1. So very great trial. PCSK9 vaccine is in process. A single vaccine reduces LDL by 50%, and this is sustained for 1 year. So if this comes out to be reality, vaccine once a year will be the new way to target atherothrombosis or atherosclerosis. Seroglitazar decreases the triglycerides, predominantly has other actions also, and is approved for type 2 diabetes and NASH, but no outcome data is available. Triglyceride reduction, you can see, is phenomenal, 45 to 60%, 62%. So in summary, LDL cholesterol has a causal relationship with ASD, and lowest is best in the extreme high risk group. Lowering of LDL-C level to very low levels, like 30 or even up to 10 is safe, as shown by the 4-year and Odc trial, and provides incremental benefit without any side effect. LDL lowering to 65 results in arrest of progression of atherosclerosis, and if you lower LDL below 50, it results in regression of atherosclerosis. LDL can be lowered up to 85% by a combination of high-intensity statins, ezetimibe, and PCSK9. And inclisiran has recently been approved by US FDA and will emerge as a very patient-friendly option in combination with statins and ezetimibe to fulfill the goal of running the race to the bottom of LDL in a very high and the extreme risk group. Thank you very much for your kind attention.
Thank you very much, sir. Wonderful presentation. As you know that the LDL cholesterol target we are reducing every year or every 6 monthly, and less than 30 milligram or up to 30 milligram has been shown a dramatic result. And more importantly, you have shown that this target can be achieved by the PCSK9 inhibitor availability. So, we have got another friends with us. Sunil is here and Satish is here. Would you like to question to Dr. Manoria?
Yes, sir. Thank you, Dr. Manoria, for the wonderful talk. I'm Dr. Bansal from Agra, old city of Professor M.C. Gupta and Professor Vahan, your old friends. I was just remembering your presentation, which used to give in keynote lectures in API conferences. And your presentation was similar to what we used to hear 20 years back in API conferences. So my question is related to triglyceride. So there is a lot of confusion with triglyceride lowering. So what's your take with the use of fibrates and lowering of triglyceride?
We, the diabetologists, always target triglycerides.
Yes, sir.
It may be true that lowering of triglycerides may reduce ASCVD events, but there's no documentation. Reduce It trial was the first trial which showed that if you lower triglycerides, it reduces reduction in the cardiovascular events. But subgroup analysis showed that reduction in cardiovascular events is same, whether your triglyceride is more or your triglyceride is less, clearly indicating that Reduce It trial, which was done in patients with hypertriglyceridemia, to test this hypothesis that triglyceride lowering will reduce cardiovascular events. The trial came out to be positive. There was a lot of enthusiasm. The icosapent ethyl is approved by ACC in this subset of patients, but the mechanism of mechanism of improvement in cardiovascular events is a big question mark. So at the moment, a cause and effect, which means if you reduce triglycerides, you will reduce cardiovascular events, is not proven. It is a risk factor. If you have hypertriglyceridemia, there are a lot of adverse things which have been reported. But at the moment, we do not have trials. Trials with fibrates are ongoing, but none of them have come out to be positive. If you look at the ADA guidelines, they say fibrates do not improve the outcome. You can reduce triglycerides in patients more than 500 to prevent pancreatitis. But we are expecting that some diabetologists should conduct a large trial, because Indian dyslipidemia always talk of hypertriglyceridemia, but it has not been shown. It may be true.
Yeah. Thank you. Pratik, do you want to?
What is your practical approach? Yeah, Manoria sir, what is your practical approach when a patient comes, like at this level you give statin high dose, then add ezetimibe, and then you add PC. What are the candidates for PCKS9? Like where you are
if
using
you look at the
injections?
lipid association for the low risk, the LDL target is 100, less than 100. For the moderate, it is less than 100. For the high risk group, it is less than 70. For the very high risk group, it is less than 55. For the extreme risk category A, it is less than 50, optional goal of 30. And for the category B, it is less than 30. So you have to risk stratify the patient and find out what is the target for this subset of it. Suppose you are in the extreme high risk group. Your target is category B 30. Then you have to see what is your LDL at baseline. Suppose your LDL at baseline is 80, it may be possible that high intensity and statins may be able to bring it down to the target. So roughly statins would reduce by 50%, ezetimibe by another 20%. So suppose you have 80 or 90, 70% reduction of 80, which means 40. So reasonable. But your baseline LDL is 140. I think right from the word go, you have to use statin, ezetimibe, PCSK9, and whatever is available. So depending on the baseline LDL, depending on the risk of the patient, both are important. You have to categorize your patient. He falls into which risk group. If it is extreme risk group, you have to be very aggressive.
Yeah, Dr. Alok Rai, please.
Sir, I want a question from Professor Manoria. The benefits of eicosap and ethyl have not been translated in other omega-3 fatty acid trials. Why?
See, this was a very pure form. It has only icosapent, no other thing. So that's why the trial says all other trials with omega-3 has been negative. The other trials have not used in the dosage of 2 grams BID. They have used in much lower doses. So that is perhaps the reason. They have not used in such high doses.
It is very costly also, no, sir? What is the
very
cost
costly, just like PCSK9 inhibitor. Why it is costly, we do not know. We asked many people from the United States why it is so costly. Is not clear. It should be very cheap, but we don't know what is the reason. Very, very cost, just equivalent to PCSK9.
Yeah. So thank you very much, sir.